Hi, this is Dr. Bhavin Chankaria, and I'm going to present a summary of the position slash white paper from the Society of Chest Imaging and Intervention, SCII, SCII for short, where we've looked at the indications and the role of CT chest in COVID-19. And the reason for doing this is essentially because of the significant abuse of CT scan and the way in which it is used even in asymptomatic and mildly symptomatic patients. So the authors are from all over the country. We have Lena, who's done a commendable job putting the paper together. And then Mandeep with his erudite comments from PGI Chandigarh, Ashu, who's driven the process from All India Institute, and Parang, Amit, Aparna, Abhishek, and Sham, who've helped in creating this document. So we're just going to basically talk about the diagnosis, management, and follow-up. The entire document is up at the SCIRAD site, that is sciirad.com, and would also be available at other social media sites. So, CT chest and COVID-19 for diagnosis would be currently indicated in moderate to severe symptomatic patients, breathlessness, falling oxygen saturations, suspected to have COVID-19 for quick triage. A cough is not an indication. It is indicated in asymptomatic to minimally symptomatic patients only when RT-PCR testing is not available, or when RT-PCR testing is available but the results are delayed due to backlog or logistical issues by more than 48 hours, and the delay changes the way the patient is managed. Thirdly, when there is a high clinical suspicion of COVID-19, but the RT-PCR report is negative, and again, where the findings of the CT would make a difference to management. And lastly, this would be left to the discretion of the referring doctor or the physician managing the patient. There could be other unique or individual situations, such as a patient has to undergo emergency surgery, and RT-PCR testing or rapid testing is not available, or the results will not be available in time, and the delay would change management. However, the routine use of CT scan as a pre-admission or pre-surgical test in non-emergency situations is strongly discouraged. CT chest is not indicated for diagnosis of COVID as a routine evaluation in asymptomatic or minimally symptomatic patients. And to repeat, cough is not an indication. It is not indicated for routine pre-admission or pre-surgical evaluation when RT-PCR testing is available. And it is not indicated just because patients or relatives want or demand a CT scan to check status of the lungs for apparent peace of mind. What about management? So CT chest is indicated when the patient is symptomatic or the symptoms are worsening, and the findings on the CT scan as against on radiographs make a difference to management. CT chest is indicated when there is a high clinical suspicion of coexisting disease such as tuberculosis or interstitial lung disease that would make a difference to the management of the patient. And CT chest is indicated in any other clinical scenario where the findings on the CT are likely to make a tangible difference to management. So this is entirely at the discretion of the treating doctor or doctors or the doctor team, including at or immediately after discharge, if again that makes a difference. But CT scan of the chest is definitely not indicated as part of a routine evaluation, as part of a routine protocol. So there are some hospitals where CT scans are done at day 0, day 3, 6, 9, 12, etc., and that is discouraged. Again, patients' relatives wanting regular check CT scans to see the status of the lung. CT chest is not indicated for this. Then we come to the last set of indications, and that is for follow-up. CT chest is indicated for specific clinical situations such as the patient not improving or worsening, is symptomatic, or has PFT abnormalities, and indicated in any other clinical scenario where the findings on the CT scan are likely to make a tangible difference to management. So, again, entirely left to the discretion of the treating doctor to decide whether the CT scan is appropriate for that patient in that particular clinical situation. But CT chest is not indicated for follow-up as just a routine scan to check the status of the lungs and or because the patient or the relatives want to check the status of the lungs. The scan protocol for diagnosis and staging would be a single volume end inspiratory scan reconstructed at 1 or 1.5 millimeters at 0.5 to 1.25 contiguous overlapping intervals, reconstructed in high but not in ultra high resolution. And in case thrombosis or thromboembolism is suspected, then a CTPA may be performed using a standard CTPA protocol. But it is assumed that these patients would likely be quite symptomatic and therefore would perhaps be in hospitals. But that doesn't stop CTPAs from being done in private setups, depending upon that particular individual or that geography's situation. For follow-up, the CT scan should be with an ILD protocol with supine volume inspiratory and expiratory images. However, prone imaging can be discretionary and may be done if required, but is not mandatory. For follow-up, if needed for the evaluation of perfusion defects, if they make a difference, then a CTPA with dual energy may be performed. The report should cover the following points: the pattern of disease, which would be a narrative description on the ground glass consolidation, etc. Extent of disease, CT severity score out of 25 has become the standard of care in our country and therefore should be used because everybody understands the language and the implications. An automated scoring method, for example, those supplied by vendor companies or other AI-based companies are not to be used because of the significant variability and the fact that they're not really available all over the country. Any other superimposed complication that suggests a superadded infection should be mentioned. Additional lung findings of pre-existing disease should be mentioned. There should be a mention of the mediastinum, hyla, pleura, and the chest wall. Additional findings such as coronary calcium, fatty liver, renal calculi should be mentioned. The MPA diameter may be mentioned. This is not an absolute necessity. And the CORAD's grade, which is a confidence system, should be mentioned if it's 4 or 5. If COVID-19 is not seen, then we can just say that there are no COVID-19 scans or there are no findings of COVID on the CT scan. And if the CT scan is not being done for COVID, then please don't say that this would represent CORADS 1 or 2, given the current pandemic. It makes no sense at all. Similarly, CORAD 6 makes no sense. All we have to say is that in a patient who's known to be RT-PCR positive for COVID-19, these are the findings consistent with the diagnosis. Here are some examples of CORADs. This is 1, essentially normal scan. 2, this is tuberculosis. 3, truly indeterminate, where we have some ground glass, but we don't know what this is. 4, this is perivascular subpleural ground glass, which after some experience and expertise, we would be quite confident in saying this is likely to be COVID. Similarly, this is also suggestive of COVID, but because these are not absolutely characteristic patterns, we use CORADS 4, and CORADS 5 is when the pattern is absolutely definitive for the diagnosis. The CT severity score is done for 5 lobes: right upper, right middle, right lower. The left upper and lingula are treated as one, and then the left lower lobe. So here, the right upper lobe is not involved, and therefore the score is 0. The right middle lobe shows less than 5% involvement, so the score is 1. Here, the right lower lobe shows 5 to 25% involvement, so 2, etc. For the treating doctors and any other referring doctors listening to this, remember this is a crude score because you could have 10% involvement of the lungs in all the lobes, and the score would be 10, 2, 2, 2, 2. And it would be 20% involvement of the lungs, and the score would still be 10. So please understand that there are limitations. But since the CT severity score out of 25 has become the de facto standard across the country, we recommend that it should continue to be used. We should be aware of the various differential diagnoses. This image has been provided as a reference point for anyone who wants to refer to these, but we should be a little careful depending upon the clinical situation. So this, in short, is our recommendations from the Society of Chest Imaging and Intervention, a position statement and a white paper to discuss the indications and the role of CT chest in COVID-19. Stay safe and thank you for listening.